I'm Lowo Adeyemi, and this is Designed for Recovery, a global platform where design intersects with dignity and spaces become instruments of equity, healing, and humanity. Today, we turn our attention to one of the most pressing, heartbreaking, and urgent challenges in healthcare today: maternal health inequity. And our focus will be designing for maternal health equity, where we'll be addressing racial and geographical disparity through intentional spaces. This episode is about more than walls and corridors. It is creating places where every mother, regardless of race, zip code, or income, has access to safe, dignified, and life affirming care. Before we devise effective solution, we must confront the stark reality. In the United States, Black women are 3 to 4 times more likely to succumb to pregnancy-related complications than their white counterparts. This disparity persists across various income brackets, educational attainment, indicating that the issue transcends mere access of financial resources, rooted instead in systemic inequities and entrenched biases. In rural regions, often referred to as maternity care deserts, nearly half of the county lack any obstetric services whatsoever. Consequently, women are compelled to travel for hours to give birth, frequently with harrowing repercussions. On a global scale, the inequity becomes even more pronounced in low-income nations. Maternal mortality rates exceed those of high-income countries by over 100-fold. Yet, here lies the crux of the matter. Where medical intervention is undeniably vital, the design of healthcare environments either exacerbates or mitigates this disparity. Let's consider why design matters in maternal equity. Many individuals presume that maternal health is solely a medical concern. However, design is inherently subjective. Spatial accessibility dictates whether a woman residing in a rural locality has a birthing center within reach. Environmental factors such as cold, sterile, and intimidating delivery rooms can alienate patients, particularly women of colors, who often feel marginalized during clinical interaction. The lack of cultural attuned environments can exacerbate the feeling of invisibility, thereby perpetuating distrust in healthcare system. Design either exacerbates disparity or mitigate them. When executed with intention, design has the potential to restore trust, bridge geographical divides, and ultimately save lives. Now, how do we address spatial disparity through design? Let us commence with the issue of racial inequities. Envision a bathing suite that transcends the sterile ambience of a surgical theater, embodying the warmth of a home, inviting hues, artworks that resonate with the local community, and environments conducive to rituals, prayer, or familial presence are important. We must know that representation is paramount. When women of color perceive themselves mirrored in their surroundings, it fosters a profound sense of belonging. Let's also consider how to design for autonomy. Numerous Black mothers have articulated experience of being disregarded or marginalized during labor. It is imperative that these spaces empower patient autonomy. Versatile bathing suits designed to accommodate both natural and medicalized birth afford mothers a sense of agency. Adaptable furnishings, access to bathing tubs, and adjustable lighting collectively enhance their control over the birthing experience. I like to make mention also of trauma-informed maternity care for women who have endured discrimination or past trauma. The design of a space can either provoke distress or promote solace. Trauma-informed maternity units emphasize privacy, unobstructed sightline, and designated communication zones for staff and families, thereby mitigating feeling of vulnerability. Now let us dive into the geography of maternal inequity. The first on this is community-based birthing center. In rural or underserved regions, small-scale birthing center can facilitate safe deliveries in proximity to local populations. This facility need not replicate the expansive nature of large hospitals. Rather, they can be modular, adaptable, or seamlessly integrated into existing community clinics. The second consideration is mobile and telehealth enabled care. Mobile maternal health units that are equipped with ultrasound technology, prenatal monitoring, and teleconsultation room extend healthcare access into desolate areas. This design must prioritize technological integration, featuring private telehealth room within clinics where women can engage with specialists located hundreds of miles away. And lastly, on this segment is networked care. Rural birthing center ought to be interconnected, both digitally and physically, with regional hospitals. This necessitates the establishment of clear transfer routes, the inclusion of helipads or ambulance bays, and the implementation of remote monitoring capabilities. In this segment, I will discuss postpartum gap. Here is a sobering fact. The majority of maternal death happens after childbirth. Yet, numerous facilities are structured to expedite the discharge of women, frequently without sufficient follow-up. Here are few design interventions to mitigate this challenge. We must consider a postpartum suite, that is, rooms meticulously crafted for recuperation, breastfeeding assistance, and mental health evaluation, even after childbirth. Also, we must consider the inclusion of community halls, dedicated spaces within maternal clinics designed for peer support group, lactation consultancy, and nutritional education. And the last on the segment, which I believe is very vital, is the integration of mental health spaces. A softly illuminated private rooms designated for screening and therapy related to postpartum depression. Before we come to the end of this episode, I would like to share with us 5 principles of equitable maternal design. The first of them is access. There is a need to ensure geographical proximity through community-centric and mobile framework. The second of the 5 is agency. We must empower women by providing diverse options in their birthing environment. The third is affirmation. This talks about the embodied culture, identity, and dignity in every design element. The fourth is continuity. Design consideration must be extended beyond childbirth, encompassing postpartum care, family integration, and long-term wellness. And lastly is connection. It is very important to harness network, telehealth, and community collaborations. Design for maternal equity transcends mere luxury. It embodies a fundamental pursuit of justice. We must ponder this. What if every mother, irrespective of her race or geographical location, could deliver her child in an environment that venerates her, uplifts her, and safeguards her well-being? Healthcare design possesses the transformative potential to address that profound inquiry. And as we conclude, let us bear in mind, maternal health inequity are not a foregone conclusion. They are intricately shaped by systems, policies, and indeed by design. The manner in which we create environments can either perpetuate disparity or actively dismantle them. In our hospital, clinics, and birthing center, each design decision is a moral imperative. Thank you for joining me today. If you enjoyed this episode, don't forget to subscribe, like, and share within your community. And until next time, let us continue to craft with equity, dignity, and humanity at the forefront. I am Lowo Adeyemi. Bye for now.